Good afternoon. It's Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Lo siento, estoy hablando en inglés. Bienvenidos a este canal, esta charla de Atul Goel. Se llama El Rey de Zoom porque él hace muchos programas en todo el mundo, incluyendo Latinoamérica. Yo acabo de descubrir. Entonces, déjame introducir al host, Byron Salazar. Bienvenidos, Byron.
Bienvenidos a todos. Quería agradecerles y indicarles que la charla del día de hoy será en inglés, por lo tanto, permítanme hacer las introducciones pertinentes en el mismo. Good morning to you all. My name is Byron Salazar, and as the president of the Cavernous Society of Neurosurgery, it is my pleasure to welcome all the participants today for this fourth session of our continuing medical education course in neurosurgery, held by the Cavernous Society of Neurosurgery and its academic committee. I welcome all the eminent speakers and guests from all over the world that are here with us in this virtual event, and we appreciate you taking this time to share your knowledge and vast experience with all of us. These seminars are completely conducted on a digital platform on Neurosurgical TV and has brought us together in this time of social distancing due to COVID-19 pandemic. So I would like to congratulate Dr. John Bennett for this monumental effort. And we are proud to announce that these webinar courses are being conducted along with the cooperation of the International University of Ecuador, which assists with the academic support of these events. And we have a truly special guest today, and I already know his lecture and the following discussion will help students, residents, and young neurosurgeons to expand their mental horizon and will help them and all participants to become better surgeons. I would like to thank for the presence of master surgeons like Juan Luis Gomez Amador, Professor Shan, so many others that are here with us. And now I would like to present to you Professor Jorge Salazar from Ecuador, head of the Department of Neurosurgery from the Metropolitan Hospital, which is going to introduce the today's extraordinary speaker.
Hello, good morning, good evening to everyone. On behalf of the Ecuadorian Society of Neurosurgery,
I'm sorry, it's my fault. I muted the wrong person. Sorry. Just unmute yourself there. Yeah, unmute yourself.
can you hear me now?
Yes, I'm sorry. That was my fault.
Yes. Okay, I would like to give all of you the best welcome to our panelists, attendees, and of course, our renowned and one of the most experienced neurosurgeons in the world, Professor Atul Goel, who will present his lecture on surgery on lesions involved cavernous sinus. Professor Atul Goel is head and professor of Department of Neurosurgery at King Edward Memorial Hospital and SETS GS Medical College, Parel, Mumbai, India. He is chief editor, International Journal of Neurology and Neurosurgery, Journal of Craniovertebral Junction and Spine, and advisory board member of other renowned journals. He is honorary member of Japan, Venezuelan, Bangladesh, and Egyptian neurosurgical societies. He is the past president of the Asian Oceanian School-Based Surgery Society, author of many books, book chapters, and publications. Professor Atul Goel presents a great experience on cavernous sinus surgery, and he started as a school-based neurosurgeon in 1986. In 1996, Professor Goel published his book, Neurosurgery on Complex Tumors and Vascular Lesions, with extensive chapters on cavernous sinus surgery. Among his multiple publications and research projects, there are several articles about the role of cavernous sinus in eye movements, the importance of meninges in tumor surgery approach, meningeal architecture of cavernous sinus. In 1997, he published about the extradural approach to lesions of cavernous sinus, several articles in relation to treatment of chordomas, meningiomas, trigeminal neurinomas, cavernous angiomas, tuberculomas, and diverse surgical techniques and approaches to cavernous sinus lesions. I really appreciate Dr. Atul Goel for his valuable time and disposition to collaborate with our educational program in neurosurgery. Welcome, Professor Atul Goel. The session is all yours.
Thank you, George. Thank you, Byron. Thank you, John. And it is my great pleasure and very big honor to be present for the Ecuadorian Society of Neurosurgery. And I see the mountain behind you, George. Wonderful. Is it in Ecuador or some other country?
Yeah, this is the Cotopaxi volcano in Ecuador, one of the highest mountains and active volcano.
Okay, so I hope I can come and see this beautiful volcano sometime in my life. And Byron has already invited me to the Latin American Society of Neurosurgery, so I hope I can come. So let me just begin my lecture, and I'm going to talk. Can you see my slide, George?
Yes.
Yes, I can see.
So basically, I will give my philosophy, my strategy, and my technique of how to operate on the lesions involving cavernous sinus. Basically, it is a philosophical kind of presentation. Cavernous sinus, you know, there is no question that those who want to do cavernous sinus surgery have to learn anatomy and have to learn anatomy in a very, very fantastic manner. There is no shortcut to doing cavernous sinus surgery. And these are my books. This is the one I wrote in 1996. Sorry for that. Just a minute. So this is the book I wrote in 1996, Lesions Involving Complex Tumors and Vascular Lesion. And if you see the cover page, you see the wonderful dissection that was done in 1996. The whole petrous bone has been removed. Facial nerve has been mobilized. Carotid artery has been mobilized. Gasserian ganglion has been mobilized. And this is my exposure, skull base exposure in 1996. And I will talk to you next lecture on craniovertebral junction and spine. So keep this title for the next lecture. So cavernous sinus is a wonderful structure. Nobody has ever talked about the role of cavernous sinus in eye movements, in vision. And there are several articles of mine mentioning as the role of cavernous sinus. It is not just a venous plexus. It has got several functions in eye movements. The cavernous sinus of a lion is much smaller than the cavernous sinus of a deer, because the deer's eyes move front and back very fast, very rapidly. It moves because it has to jump and it has to also see how far is the lion. So the eye movements are very rapid, front and back, front and back. The lion's eyes do not move much. It has to only look towards the tail of this deer, which is running, and catch hold. So because the eye movements are very rapid and very quick, the cavernous sinus is much bigger in a deer than in a lion. The eye is only 30 degrees in a lion. In human being, it is 70 degrees. In a deer, it is 180 degrees eye movements. So bigger the eye movements, bigger the cavernous sinus. And it has also several functions which are discussed in my papers, and I wish that you please read my articles. Cavernous sinus is very intently related to the eye. There is venous plexus behind the eyeball. Eyeball is a hydrodynamic it is high degree of hydrodynamics. The lens, the aqueous humor, the vitreous humor, the turgidity of the eyeball is very important for the retina to function. And this turgidity of the eyeball is maintained by the venous plexus and the quick drain off that the venous plexus present to the cavernous sinus. So my philosophy is that cavernous sinus is very intimately related to the eyeball and to the function of the eyeball and to the retina. You see, this is the circle of Willis. Similarly, there is a circle of relief. I like to call it circle of relief of cavernous sinus. There are intercavernous sinus connections, and there are huge venous plexuses. These are the largest venous connection in the whole of the skull. So cavernous sinus and intercavernous sinuses are very important for the function. If you press the eyeball like this, the pressure will go instantly to the opposite cavernous sinus. And there will be diplopia for some time, and then the pressures will be regulated. So there is a kind of a balance which the cavernous sinus provides and also protects the eyeball. So when there is cavernous sinus thrombosis, the eye movements are lost, not because the nerves are gone, but because the venous function of the cavernous sinus is lost. The venous drainage is lost. So cavernous sinus has a big role in eye movements and vision. So it has a role in vision. Cavernous, this hand is like cavernous sinus, and cavernous sinus protects, supports the eyeball and its various contents. So there are several other functions of eyeball which we have discussed in our articles on this subject. And unfortunately, my point, this is not running. So the eyes, what the eyes of various animals, of course, are important, but what lies behind the eyeball is also important. And what lies behind is, of course, the brain, but also the beauty of cavernous sinus. So cavernous sinus is very closely related to the sphenoid sinus. Cavernous sinus is very closely related to the pituitary gland. Cavernous sinus is intimately related to the carotid artery. Pituitary gland is not only located extracranial, but it is located in a, whether it is intracranial or extracranial, nobody knows. It has a special cavity and special relationship with cavernous sinus. So these relationships are very important for the function of the pituitary gland, for the function of the cavernous sinus, and for the function of the sphenoid sinus. Sphenoid sinus and paranasal sinuses and oral mucosa are the most vascular structures of the body. When the air goes inside the nose, the temperature outside may be hot or cold, but as soon as it reaches the nose, because of the turbinates and because of the movements of the air, and presence of vascular mucosa, it becomes normal temperature. When you drink hot water or cold water, as soon as it goes in the esophagus, it is normal temperature because of the vascular oral mucosa. So this is, paranasal sinuses are like air conditioners of the body. They give information of the external temperature to the cavernous sinus, and then the cavernous sinus gives that information to the pituitary gland, and then this master pituitary gland regulates the whole body. The temperature of inside the body is given to the cavernous sinus by the carotid artery. So there is, the structure and function are interrelated. more the function, structural innovations by nature are due to functional needs of the body. The other beautiful thing that you see in the cavernous sinus is the relationship of the carotid artery, relationship of the sixth nerve. This is the third nerve, this is the fourth nerve, this is V1 division of the trigeminal nerve, this is V2 division of the trigeminal nerve, V3 division goes before the cavernous sinus. So these nerves, all these nerves are located in the lateral dural wall of the cavernous sinus. They are not intracavernous, they are interdural, these nerves located within the confines of the dura of the lateral wall of cavernous sinus. So I will discuss this anatomy with you very soon. So this is from Arabic legacy. It means that the meninges are the mother of brain. So meninges are born first, brain is born next, and the last to be born is the bones. So bones are the weakest part of the human body, and meninges are very strong. So ectoderm, neuroectoderm. So these are born very early in the evolution. Brain is born later, and bones are the weakest, born the last. Now I will discuss with you about the dura and the magic of dura. You see, the dura contains the brain. It is impermeable membrane. No infection, no external influence can influence the brain. So it is a very highly compact, protected environment that the dura provides. And the brain has a special immunity to various infection and to abscessing. So the dura is a very compact membrane, and dura is important to understand, and I will talk to you about the dura and its implications for cavernous sinus surgery. So I am involved in cavernous sinus surgery for a very long time. And in 1998, I wrote this article about impact of arterial displacement on strategies of cavernous sinus surgeries and cavernous sinus surgery. So these are very important articles for me. And this had great influence during that time, 25 years ago, about surgery of cavernous sinus. At that time, surgery of cavernous sinus was not so popular 25, 30 years ago. So this was my article. It shows that carotid artery can be encased by the tumor. Carotid artery is displaced by the tumor. So these tumors are different. So these pictures are from my book, from my article in 1998. Like, you can identify the pathological nature of the tumors by the relationship with carotid artery. When it is compressed, it is different. When it is displaced, it is different. When it is encased, it is different. So this was my article. So I work in a public hospital, in a public free charitable institute, which caters to the, in general, to poor population of our country. And the most important thing is our patient volume is without any doubt the largest volumes in the world. So I have been involved with this hospital and with this very complex skull-based cases for a very long time. You see this kind of tumor I operated in 1993. You can imagine carotid artery encasement, basilar encasement, PCOM encasement. And I had removed this tumor in 1993, this meningioma, and this lady is still alive. Patient had presented with blindness of both eyes at that time. She's still blind, but still she's alive more than 27, 28 years ago. I did this operation in 1995. You see how the tumor is going in the orbit, in the cavernous sinus, encasing the carotid. So essentially, we need very big experience to do these kind of cases. This was anterior clinoidal meningioma. I had left some tumor behind. No radiation was given even at that time, and this patient is also alive. This patient did not do any follow-up imaging, but this patient is also alive. How to attack the tumor, how to understand the tumor, how to debulk the tumor, how to demolish the tumor, how to avoid coagulation, how to dissect in the subarachnoid spaces, and most importantly, how to respect the membranes is very critical for a neurosurgeon. This was another tumor I operated. You can imagine 24 years ago, cavernous sinus involvement, basilar involvement, petrous apex involvement. So that is my power, that number of cases I have been doing for a very long time. And my hospital is giving me this opportunity to do several of these cases. So this is a tumor behind the orbit and in the cavernous sinus. Both tumors are benign tumors, and both tumors, and this patient in 1997, first I removed the orbital tumor, and then we removed the cavernous sinus tumor, and both these tumors are removed completely. And this boy, you see, is completely intact. Vision in one eye is absent, but nobody can know that he is not able to see from one eye. Only I know that he does not have vision in one eye. But you see, eye movements are normal, and he's also alive for several years without any major issue. My main contribution to this subject is understanding of the dura. And in 1997, I described extradural approach for tumors inside the cavernous sinus. Of course, we know of the work of Vinko Dolenz. He described extradural approach to aneurysms of this area. He also described trigeminal neurinoma, but this was the first article which described intracavernous sinus lesions extradural approach. Cavernous sinus is an extradural entity. So extradural approach is possible and is the most wonderful approach for cavernous sinus tumors. I will now talk to you about the tumors involving cavernous sinus and the relationship with the dura. So this tumor is the most difficult tumor in neurosurgery. This is intracavernous hemangioma or cavernous hemangioma of cavernous sinus. This was the first report in the literature showing complete resection of these tumors, this tumor. This is the most vascular tumor of neurosurgery and most benign tumor. It is a primary intracavernous sinus tumor. It is located within the confines of the cavernous sinus. The dura of the cavernous sinus is completely intact. It goes towards the intercavernous sinus dura, goes towards the orbit, goes towards the Meckel cave. It encases the internal carotid artery. It is an extremely vascular tumor. You touch and it bleeds, but I described this tumor is extradural approach for these tumors. This is an extradural entity, and extradural approach is the most beautiful tumor. So even when the tumor becomes huge like this, it goes towards the intercavernous sinus, goes towards the Meckel's cave, goes towards the orbit. Lateral wall of the dura remains intact. So this is a very important anatomical landmark or understanding that the dura is intact. And accordingly, you have to decide how to operate on these tumors. So we described this extradural approach for intracavernous hemangioma for the first time in the literature on the basis of my experience with 13 cases in the year 2003. Now my experience with these cases is 47 or 48 cases, which is the largest in the world. Extradural, respect the dura. Cavernous sinus is an extradural entity, and you can approach this tumor extradurally. Many of these cases come with headache, and many of these patients come with eye movement disturbance. And the only treatment for this is resection of this tumor. And I will briefly show you one video. Of course, this surgery has to be done in a vascular situation. Bleeding. So what a skull-based surgeon or cavernous sinus has to do is don't worry about bleeding. You see this, I'm doing extradural exposure. This is V2, this is V1. And I am trying, you see blood. So most important thing is try to avoid getting too much worried about blood. So I am extradural. So this is V2 division, V1 division, and here will be foramen ovale. I'm trying to expose this tumor from the Parkinson triangle. You see, this is right side. This is the right-sided surgery. Too much bleeding. This is a very old case, of course. Then first thing that you have to go is, and you will be surprised that this is not an edited version. I am editing on my screen. The first thing that you have to expose is the sixth nerve, and this is intracavernous carotid artery, and then the tumor has been resected. So in short, extradural exposure is a beautiful exposure, and this is the third nerve involved, sixth nerve involved, and within 2 months of surgery, you get the nerves back and you get the smile back. And there is no other treatment like radiation and all may not work. Recently, some people are talking about radiation, but radiation does not work here. You have to do operation, and you have to operate in a bloody field. Now, another tumor I will show you, intracavernous cavernous hemangioma. Just see, I'll rapidly show you this extradural approach. This is transgastrian ganglion approach. I am working through the cavernous, through the gastrian ganglion. And I am opening the gastrian ganglion, then working within the fibers of the trigeminal nerve. And then I'm removing this tumor, which is a vascular tumor, very heavily vascular tumor. You have to first identify and save the sixth nerve, then identify the carotid artery and save, and then you have to coagulate the lateral trunk of the cavernous sinus, which supplies these vascular tumors, and then you have to remove these tumors in a very efficient manner. You see here, I am trying to coagulate the meningeal, this branch of the cavernous sinus, and then I am removing the tumor from the cavernous sinus. And as I have mentioned to you, these are very, very vascular tumors. And if you are afraid of blood, then you should not be doing these tumors. If you want to accept the challenge of bleeding, if you want to accept the blood loss, and you are geared up with your anesthetist and with your team and with your assistant, then you can certainly give new life to this patient, because these are benign tumors. These are vascular tumors, all right, but these are completely benign, and you can have, you see intracavernous, this is the carotid artery here, and no question that surgery is difficult. I have already told you that these tumors are amongst the most difficult neurosurgical tumors. So this is pre-op and post-op. Most important is that they remain within the dura. You have to identify the sixth nerve and save the sixth nerve early. Third, fourth, and fifth nerves remain in the lateral wall of the dura. So you don't have to bother about this as long as you're working within the dura, and you can remove these tumors beautifully. This was another case where there is a cavernous hemangioma or cavernous sinus. You see the lateral dural wall is intact, encasement of internal carotid artery going towards the intercavernous sinus, Meckel's cave, orbit. There is an aneurysm here. So I remove this tumor extradurally and clip the aneurysm. These are difficult neurosurgical problems. This is another case, large tumor, and has been removed. As I mentioned, my experience is now about 46 or 47 cases, which is the largest. These are rare tumors. Now I want to show you common tumors, pituitary tumors, and how the relationship of pituitary tumors can influence your surgery, and what my contribution in this field is. So I have got several articles on pituitary tumors and what the relationship of pituitary tumors with dura. And there are, you see, I'm giving you these references and you can have a look on these papers. So many a times pituitary tumors become very large and huge, but they are benign. You see, there are cystic changes, necrotic changes. They can become very huge and massive in size, but radical surgery can give an opportunity to give a new life. So first thing that we described about 25 years ago for the first time in the literature is when these tumors become big, the dura of the diaphragm celli is elevated on the dome of the tumor. The understanding before that, and before we described, the understanding was this tumor pierces the diaphragm celli, and this tumor in the suprasellar region is subarachnoid in location. So we described that the diaphragm celli is elevated on the dome of the tumor for the first time in the literature. You see, the diaphragm is elevated like this. The tumor is subdiaphragmatic. It is suprasellar but subdiaphragmatic. The entire tumor is surrounded by dura. So this is intradural tumor, and this is very important to understand. You see, when there is a small nubbin of tumor like this is also dura. So it is completely surrounded by dura. And this is, if you have to do large pituitary tumors, you have to have this information, because if you don't have this information, you cannot do this tumor. You see this nubbin of tumor here, this is also dura, this whole thing is dura. So the whole tumor is interdural in location. This is intracranial, but it is not subarachnoid, it is subdural or intradural in location. This tumor which is going in the brainstem like this is of course having that relationship, but a dura protects it. Dura protects, and there is dural cover. So this is very important thing that we described about 25 years ago. Tumors which go in the cavernous sinus. You see, there are some tumors which enter into cavernous sinus. So the lateral dural wall is intact of the cavernous sinus. This is dura of the diaphragm. Lateral dural wall of the cavernous sinus is intact. Tumors which involve the cavernous sinus, we graded them as grade 2 pituitary tumors. You see, tumor is involving the cavernous sinus. The diaphragm is involved. The diaphragm is not pierced. The diaphragm is elevated. The lateral wall is intact. Cavernous sinus, the medial, so cavernous sinus is an extradural entity. So this is completely within the dura. These are grade 2 tumors. So when the tumor involves the cavernous sinus, the lateral wall is intact, diaphragm is intact, we label it as grade 2. Sometimes the diaphragm is very much stretched, tight like this. The lateral wall is tight like this, but not transgressed. These are grade 2 tumors. Now you carefully look at this slide. You see the cavernous sinus is involved by the tumor when the carotid artery is encased circumferentially. The diaphragm is intact. Now you see this slide, the diaphragm is elevated and there is elevation of the roof, dural roof of the cavernous sinus. Dura of the cavernous sinus is elevated, and this is the lateral wall of cavernous sinus. Here the lateral wall, this is the diaphragm, this is elevation of the roof of cavernous sinus. This tumor is elevating the roof of the cavernous sinus. So this is very important to understand that this tumor is intracranial, all right, but it is completely surrounded by dura. Now you see this beautiful slide, there is diaphragm celli and there is elevation of the dura of the roof of cavernous sinus, and there is lateral wall of cavernous sinus. So though the whole tumor is completely within the dural limitations. You see this beautiful slide, there is elevation of the roof of cavernous sinus, elevation of diaphragm, elevation of roof of cavernous sinus. When the roof of cavernous sinus is elevated, I call it grade 3 pituitary tumor. Grade 4 tumors are rare when it transgresses the dura, when it goes in the subarachnoid spaces, when it encases the arteries of the circle of Willis. These tumors which do not respect the mother dura mother, I call them grade 4 or aggressive pituitary tumors. So this is my classification. Grade 1 is when the diaphragm is elevated, but the cavernous sinus is not involved. Grade 2 is when the cavernous sinus is invaded by the tumor. Grade 3 is when the dural roof of the cavernous sinus is elevated. Grade 4 is when the arteries of the circle of Willis are encased by the tumor. So my feeling is this dural relationship has completely revolutionized pituitary tumor surgery. It is not that you use endoscope or microscope or whatever. It is important to understand that the dura will bulge, dura will be present, and you can accordingly design your surgery. So this is the tumor and this is the dura. So just open the anterior wall of the sella, debulk the tumor, learn the art of demolishing the tumor, learn the art of protecting the dura, and you will be able to remove this tumor in 20 minutes. And you see the whole tumor will be removed and the patient will instantly improve in the vision. This case was done in 1997 on the basis of dura. So like the fetus, which will be delivered by the uterus, and uterus is the strongest muscle of the human body, it will push the baby out. Similarly, the dura will be pushing the baby of pituitary tumor down. So you don't have to do transcranial surgery for this. And I have to tell you, 25 years ago, 30 years ago, all neurosurgeons used to do these kind of cases transcranial. So understanding that this dura, you demolish the tumor, the diaphragm cell will bulge into your field and the tumor is benign and the patient will be completely cured. So these tumors, if you know that the diaphragm is intact, you can do this surgery very beautifully and safely. If you do not know that the diaphragm is intact, you cannot operate on these tumors. Subfrontal extension was a classical indication for transcranial route, but no question, you come, you remove this from here, you debulk the tumor, the whole diaphragm will be in your picture and you have removed the tumor. So even when the tumor goes like that, you don't have to look in this respect or in this direction. You have to just remove, know the art of pituitary tumor surgery, whether you use microscope or whether you use endoscope or whether you use what is not a matter of concern. What you have to know is that the dura will come out into the field and you will have removed this tumor. You can imagine 20 years ago, I removed this tumor through the nose by microscope, just by removing this wall. Understanding the fact that the dura of the diaphragm is intact, you remove the tumor and you remove the whole tumor and nothing but the tumor and you cure the person. This was another tumor I removed 22 years ago through the nose. This was immediate postoperative. You can imagine, I just removed this anterior wall, debulk the tumor. And over the years of last 35 years, I've been doing pituitary tumor. My experience is more than 5,000 cases, which is the largest experience in the field, amongst the largest at least. Cavernous sinus, how to do and what to do is important. But what is important is to know that the dura is intact, sixth nerve is displaced by the tumor. This tumor is removed by virtue of its consistency and by the virtue of its vascularity, and you can work within the cavernous sinus in a very efficient manner. The question remains in grade 3 tumors, when the roof of the cavernous sinus is elevated, you have removed this tumor, but if you have not removed this tumor, then the chances of recurrence of these tumors is very high, and then you will have to give radiation treatment. If you know that the dural roof of the cavernous sinus is elevated, you can enter into this cavernous sinus and remove this tumor under the dura. The third nerve is, it is very crucial to understand that the third nerve will be displaced, which is also within the dural confines, and you can avoid, if you respect the dura, you can save the third nerve in a very efficient manner. Tumors which transgress the dura and involve the arteries are different, and we have to learn how to operate on these tumors. Now I will talk on another, my favorite tumor, trigeminal neurinoma. This was the article I wrote in 2003 on my 73 cases. Now we have an experience of more than 300 cases of trigeminal neurinoma. This was my very beautiful article. Here we mentioned for the first time in the literature that trigeminal neurinomas are located within the dura, interdural location, and this interdural location can be used for surgery. The trigeminal nerve the neurinoma does not enter into the confines of the cavernous sinus, does not encase the carotid artery, does not encase the third nerve. It is interdural in location. We mentioned for the first time in the literature that these tumors arise within the Meckel's cave, like acoustic tumor arise from the internal artery canal. These tumors arise within the Meckel's cave, and from there it becomes big. So these tumors can go into the posterior cranial fossa. In this article, I had said that posterior cranial fossa part of the tumor is subarachnoid in location. But as we have more and more experience, we have mentioned that even this posterior fossa component of the tumor is subdural or interdural in location. And this anatomical understanding is absolutely important if you want to do trigeminal neurinoma surgery. So in 1995, about 26 years ago, we described infratemporal fossa interdural approach to trigeminal neurinoma. You can imagine in 1995, trigeminal neurinomas were very difficult to diagnose and difficult to operate. So we did trigeminal neurinomas without craniotomy, on the basis of understanding that these tumors are trigeminal neurinoma, that is one, and these tumors are interdural in location. You can see my title in 1995, and from this article, I will show you some images. So this was removed. This tumor was diagnosed on the basis of clinical presenting symptoms of numbness and paresthesia and wasting of temporalis and masseter muscle as trigeminal neurinoma. I removed it without doing any craniotomy by interdural surgical route. And also in 1994, you can imagine how difficult these tumors must be in 1994, going into the petroclival area, going into the cavernous sinus. So this was diagnosed to be trigeminal schwannoma, and I did this in 1994 without craniotomy by just opening and widening the Meckel's cave, and you can see this postoperative image, and this was published in that article. This was another case which I did without craniotomy by just widening of the foramen ovale and then opening the dura. I do not do such cases like this anymore. I will show you what my strategy is, but what is important for us to understand is that trigeminal neurinomas are located within the dura. The other thing that I described for the first time in the literature in my article in 2003 is that you can save the fibers of the fifth nerve and you can improve the function of the fifth nerve as a series. It was described for the first time. And I have no hesitation to say that if you are damaging the fifth nerve in trigeminal neurinoma surgery, you have harmed the interest of the patient. So work within the dura, work within the dura, learn the art of demolishing the tumor, learn the art of working within bloody field and avoid coagulation. Many of these tumors or most of these tumors can be removed without a single coagulation, and we have to learn that art of demolishing the tumor. Many of these tumors go in the posterior fossa. 30 years ago or 35 years ago, all these tumors were not understood. That was one. And if they were understood, they were done in 2 stages. So in 1991, I did this operation in 2 stages. The larger tumor in the cavernous sinus was removed as first stage, and then the posterior fossa was removed as the second stage. So these tumors were removed in 2 stages. So this tumor was the posterior fossa was removed first and cavernous sinus was removed second. This was the history of these, but of course, by several people described as skull-based surgery advanced, and these tumors are definitely and always removed in a single stage now. So from 1996, we had described this lateral skull-based approach, and we incorporated mastoidectomy in subtemporal exposure, removal of the roof of zygoma, roof of condyle, roof of external canal, partial mastoidectomy. So we included mastoidectomy for the first time in the literature in subtemporal exposure. And we used to do such exposure extradural and then cut the dura and enter the tumor, and then intradural for dumbbell-shaped tumors. But now my exposures have become very limited for trigeminal neurinoma. This was a very large exposure. I now just do splitting of the temporalis muscle, do a smallish craniotomy, and then work extradural and then interdural for these kind of tumors. So most important is my hospital has given me this opportunity of very heavy experience with these tumors, which of course is the largest in the world of 300 cases. Work within the dura. Come for these dumbbell-shaped tumor, I do intradural exposure. You have to handle the superior petrosal sinus, you have to cut the tentorium, you have to work within the dura, As I mentioned, many of these posterior fossa tumors are also interdural in location, but even if it is not interdural, you have to learn the art of demolishing the tumor, and you can remove this beautiful tumor, beautiful dumbbells. And this will instantly give the patient a very fantastic life if and only if you have saved the 5th nerve fibers. If you have damaged the V1 division, you have damaged the eye and you have damaged the patient. You have to demolish the tumor, debulk the tumor, learn the art of debulking the tumor, breaking the tumor, avoid any coagulation, learn to respect the dura. Don't go into cavernous sinus or you will damage the 6th nerve. You can damage the carotid artery. And don't demolish the dura on the lateral side, because there are 3rd nerve, there is 4th nerve, there are other nerves in this territory. So work within the dura, identify a good direction and demolish the tumor. And you can remove these tumors most beautifully and most fantastically, even when there is a nubbin like this. This is not intracavernous. There is dura present all around the tumor. Break the tumor. And as I mentioned, you can remove without craniotomy, but it becomes a little cumbersome. Do a small subtemporal craniotomy, come extradural, open the dura, demolish the tumor, and you will not believe that many of these tumors I do in half an hour or 20 minutes. And that is, the whole operation will not be even 45 minutes. So these tumors are you have to understand these tumors. You have to learn the art of breaking the tumor. You see, the petrosectomy is already done by the tumor. Anticlinoidectomy has already been done by the tumor. You do not have to do any bone work. You have to do only tumor resection, and you have to respect only dura. If you respect mother dura, you have given a new life to the patient. When the tumor goes extracranial, there is also dura present. This is along the V1, along the V2 by the side of teeth, along the V3, We described 28 cases in 2010. Now I have got several cases. This is also the largest series. Most important is that this extracranial part is also interdural. So we do not do this by the nose or by maxillary root. We do make a small craniotomy and then go along. So it is a reverse skull-based transcranial route. Open the dura, respect the dura, and you can do a beautiful tumor resection. Even when the tumor recurs in an apoplectic fashion, in these massive tumors, I have you read this article where I have said the tumor recurrence, even in those cases, the tumor respects the dura. Now I will show you another tumor, which is a difficult skull-based tumor, and I will show you how it respects the dura. This is a third nerve neurinoma. If you want to remove third nerve neurinoma and save the third nerve, you have to know that the dura is completely around the tumor. The dura is not the tumor. This is soft tumor, necrotic tumor, break the tumor, and you can save the third nerve function. So we describe this interdural route. The tumor like trigeminal neuronoma arises from the Meckel's cave. Oculomotor neuronoma arises from the oculomotor cistern in this area. And as it becomes large, it takes the dura along with it. So it is an interdural, this tumor remains interdural. So the capsule, it is not a capsule, it is dura. So you debulk the tumor, break the tumor, but don't try to remove the capsule. And you can save the third nerve function in a very beautiful manner. If you think it is not dura, it is capsule, you will never be able to save the third nerve. You see, the dura is completely circumferentially around the third nerve neurinoma, and you have to save the dura if you have to save the third nerve function. This is a sixth nerve neurinoma. The only schwannoma which will encase the carotid artery is a sixth nerve schwannoma. And then I am working on the strategy of how to work within the dura in this situation. I want to show you another skull-based tumor. This is seventh nerve neurinoma. Now, as I mentioned to you, acoustic tumor arises from the internal aortic canal, trigeminal from the Meckel's cave, third nerve from the oculomotor cistern. Seventh nerve arises from the internal auditory meatus, from the region of the geniculate ganglion. Seventh nerve is interdural, completely within the dura. And if you understand that this is going to be seventh nerve tumor, that is one. It is going to be a benign tumor, that is number two. And if you understand that the dura is completely circumferentially surrounding the tumor, you can save the seventh nerve function. So this approach, this tumor can be removed in not more than half an hour. You see, there is necrotic tumor, soft tumor, open the dura, debulk the tumor, save the transit of the seventh nerve. I have never been able to restore the seventh nerve function. I have never been, but there is a possibility. So you can actually identify the seventh nerve and make an anastomosis if you have to. But if you preserve the dura, you can preserve the seventh nerve function. Lower cranial nerve neurinoma. So like seventh nerve tumor arises from the geniculate ganglion. Lower cranial nerve neurinomas arise from the jugular bulb area, and they are also interdural. They respect the dura. This is also one of my most fascinating papers. If you work within the dura, work within the dura without transiting the dura, you can not only save the function of the lower cranial nerve, you can improve the function of lower cranial nerve. So if you read this article, you will see that all my 14 patients, which I described when I described, had improved lower cranial nerve function after surgery. So these tumors arise in the region of the jugular bulb. The dura circumferentially surrounds the tumor. The entire tumor, extracranial and intracranial, is surrounded by dura, and you have to work within the dura to remove this tumor and avoid the lower cranial nerve. You see, when this tumor goes extracranial, you work within You leave the dura and you will save the lower cranial nerve function. Not only save the lower cranial nerve function, you can improve the lower cranial nerve function. So that is a very important dural relationship of the various tumors. I will now talk about second nerve neurinoma. This is C2. This is C1, this is C2, this is the vertebral artery, this is C2 ganglion, which is a very large ganglion. C2 ganglion is the largest ganglion of the spine. Gasserian ganglion is the largest ganglion of the skull. So this is trigeminal neurinoma surrounded by cavernous sinus, surrounded by carotid artery. C2 ganglion surrounded by venous plexus and in relationship with the vertebral artery. So they are very similar. Similar, like I mentioned, that Gasserian ganglion tumors are interdural in location. Similarly, C2 neurinomas are interdural in location. So we described some time ago that C2 neurinomas are like trigeminal neurinomas. This part is interdural and this part is intradural. Like we described, this part is interdural, this part is subdural. But later we said that this part is also interdural. So similarly, we said in my paper in 2008 that this part is intradural, but in 2018, I said that even this part is interdural. So here we had described 60 cases of C2 neurinomas. And in this article, I described 50 cases of C2 neurinomas. The change in policy was the whole tumor is interdural. You make an incision in the dura and you can remove this tumor. I have shown in some workshops, at least 2 workshops, removal of these kind of tumors in 10 minutes and the whole operation being finished in 20 minutes. So I'm telling you not that time is not the matter. Time is not the concern. The issue is if you respect the dura, you don't have to expose the vertebral artery. You don't have to have control of the vertebral artery. You don't have to, you just respect the dura and you can do a beautiful tumor resection. You have to learn the art of demolishing the tumor. So this is C2 neurinoma. It is going intraspinal, but it is completely interdural. Like this tumor, trigeminal neurinoma, is going in the posterior fossa like this, but it is completely interdural. So for the first time in the literature, I removed this tumor without craniotomy. And first time in the literature, I removed this tumor without laminectomy. C2 ganglion is located outside the spinal canal, as I showed you. Open the dura, work within this outside the spinal canal. Open the dura, work within the dura, and you can, there is no need for any bone work. So this tumor, you should not do any laminectomy or any vertebral artery exposure or anything. Just open the dura, respect mother dura, and you can remove this tumor in very quick time. Like I said, 10 minutes or 15 minutes, this trigeminal neurinoma should not be done more than half an hour or 1 hour. If you are doing 5-hour operation or 10-hour operation, you are not doing it correctly. You are not respecting the dura. You have to understand that these tumors are quite beautifully resectable. Now I want to go to another tumor of skull base, chordomas. Chordomas are tumors that arise from the bone. Bones are the softest part of the human body. These tumors grow big, they enlarge, but they cannot transgress the dura. They remain extradural. It is extremely rare that they will go intradural. They remain extradural, they displace the carotid artery anteriorly, they displace the cavernous sinus superiorly. They never encase the carotid artery. They never encase the cavernous sinus nerves. So they are special tumors. So this fact that the carotid artery is displaced anteriorly was first described by me about 25 years ago in this article, 26 years ago. We said that chordomas and chondrosarcomas displace the soft tissues. They destroy the bone, but they displace the soft tissue. They are extradural in location. You respect the dura. You respect the dural membrane. You know that the artery is displaced anteriorly. There is no artery here, and you can do a very beautiful resection by middle fossa subgastrian ganglion approach that we described in this article. And lateral exposure, the carotid artery is under your control, and the whole anatomy is under your control, and you can do beautiful surgical resection. This is the carotid artery and this is the dura, and you can understand that this is a clival chordoma, and you can do a beautiful resection by working within the dura of this tumor. This is the tumor. Many people now try to do endoscopic nasal route. Of course, that is a good operation, but to have the carotid under control, to have the sixth nerve under control, to have the cranial nerves under control, transcranial route is a beautiful surgical route. I just want to show briefly this video where a transcranial route has been done. You see how the nerves are under my control, how the carotid artery is, this is carotid artery completely under my control. And most importantly, the sixth nerve is under control. You see, you do it from the nose, you don't see any of this anatomy. I am not saying there is no role for transnasal surgery. Of course, there is a role for transnasal surgery, but transcranial surgery is the most beautiful under control surgery. I described the supracerebellar approach for clival chordoma. You will be surprised to hear this. You will be surprised to see this supracerebellar approach. You see here, this tumor is clival chordoma. Of course, lateral approach is the beautiful approach, but sixth nerve, you see, to identify sixth nerve early in the operation is not possible because it is displaced by the tumor. Coming from the nose, this distance becomes very big. So I removed this tumor supracerebellar. And the most important thing is the sixth nerve was under my control very early in the operation. So this is another case of clival chordoma. Transnasal will not be a good route. Lateral may not be a good route. So I did it by a supracerebellar route, and I removed this tumor in a very beautiful fashion. Even this tumor, you see this tumor to come from the nose is very possible. I'm not saying it is not possible. I'm not saying middle fossa is not possible, but I removed this tumor from a supracerebellar route. Most important is identifying and separating and isolation of both the six nerves was possible early in the operation. So this is an alternative approach. Most important is that dura is intact. Most important is that the mother dura is intact. Cranial nerves are displaced. Carotid artery is displaced. Sixth nerve is displaced. If you have this concept, you can remove these tumors easily. Not easily, but confidently and nicely. If you do not have this concept, you cannot remove these tumors. These are nasopharyngeal tumors. You see the dura is intact. In this, dura is not intact. Nasopharyngeal angiofibromas can be difficult tumors. They can be vascular tumors. They can be, they are not only extracranial, extradural tumors. So you have to know that these tumors are difficult and vascular tumors. So in the year 1992, I described transcranial route for these tumors. But if I understand that the dura is intact, so this was my approach, which I described in 1994, transcranial route. But now I don't do transcranial route because I know that the dura is intact, cranial, there is a thin shell of bone is intact. I like to do mid-facial degloving approach for large tumors, and for smallish tumors, endoscopic or endonasal approach is also useful. But transcranial route is not necessary. Although I described it, I don't use it now. So there can be other tumors like epidermoid tumors, which are dermal tumors, which are born from the dura, and they are also respecting of infections are one dangerous things which has happened more recently. Mucormycosis following COVID infections are very common. We have got in my own hospital at this point of time, more than 100 cases of mucormycosis following COVID infection in my own hospital. Many of these things involve the cavernous sinus. So this can be tuberculoma can be involved. Now, briefly, I would like to talk on meningioma, which is our mother tumor. And all neurosurgeons, young or old, learn neurosurgery from operating on meningiomas. Meningiomas are our life. How to operate on cavernous sinus meningioma is a very important thing. So this tumor is a convexity meningioma. It is benign tumor, we know it. But when this tumor goes into superior parietal sinus, they become inherently aggressive in nature. When it involves the superior parietal sinus, they are more aggressive in their behavior. When it goes extracranial or paranasal sinuses, they are almost like malignancies. We know it. And when they are primarily in the paranasal sinuses, they are malignant meningiomas. Similar with the similar concept, when the tumor involves the cavernous sinus, they are inherently aggressive. When they are primarily in the cavernous sinus, they are more aggressive in nature. When the tumor is on the lateral wall of the cavernous sinus, they are benign. When they involve outside the cavernous sinus, inside the cavernous sinus, they are more aggressive in nature inherently. And when they go into the sphenoid sinus, they become almost like malignant tumors. So this was intracavernous meningioma. I operated in 1995 and there was a recurrence. So my firm belief is, even if you do a radical resection of intracavernous sinus, which are purely intracavernous sinus, the recurrence rates are much higher. This is another tumor I had operated, and which is intracavernous sinus tumor, which is very vascular tumor, as you can see, but it was resected. When they go into the paranasal sinuses, they are almost like malignancy. So this tumor, you see lateral wall of cavernous sinus arising, there is a vascularity from here. They are benign tumors. Arising from the posterior wall of the cavernous sinus, you devascularize and you remove this tumor. These are relatively benign tumors. They are benign cavernous sinus tumor. You see this arising from the posterior wall of the cavernous sinus, this vascularity, and this has been removed beautifully, and long-term no recurrence. So this is another tumor arising from the lateral wall. They are more benign tumors. Early in my surgical experience, 25 years ago or 30 years ago, I was much more aggressive in my exposure. You see this, you can see facial nerve. I describe mobilization of the facial nerve. I describe extensive petrosectomies and all those things for petroclival meningiomas. So in 2004, I described supracerebellar approach for the first time for these petroclival meningiomas. Now, many of you know that this approach of mine, supracerebellar approach, posterior cranial fossa approach, which Sami described he described retrosigmoid approach like for acoustic tumor, but this is supracerebellar approach, which is a little different from Sami's approach for such petroclival meningioma. Is a beautiful approach, and many people in the world are doing this approach now. So this kind of tumors can be removed, and some tumor has been left behind in the cavernous sinus. And I have got a very huge series of such tumors being removed by supracerebellar route. This tumor also, even in the cavernous sinus, you can remove when it is going in the Meckel's cave. So there are many, many tumors. You see, this is the tumor, and this is after. You see the fifth nerve, you can follow inside the cavernous sinus. And this is another tumor. You see both vertebral arteries are encased by the tumor. By supracerebellar route, I remove this tumor. Just I want to show you the terminal part of this operation. Of course, I cannot show you the whole operation, but you see this tumor by retrosigmoid supracerebellar route. The whole tumor has been removed beautifully and completely. And if you are able to remove these tumors completely, you give a new life to this patient. There is a small residue here, which was missed, actually not left behind. And these tumors can be removed supracerebellar. You see the same tumor, and you see the just few glimpses of the tumor resection by supracerebellar. So I do middle fossa approach for some select tumors, of course, radical petrosectomy for some select tumors, of course, but for many tumors of this kind, I can now remove What we have to learn is the art of breaking the tumor, art of demolishing the tumor, art of cutting into the tumor, and you can do beautiful resections. This is another tumor which was done by supracerebellar route. And you see how, what anatomy you can see, beautiful anatomy. Of course, the video quality is not good here, but what I want to show is not the quality of the video, not the quality of the surgery, not the quality of the technique, but the quality of exposure that you can get after this kind of surgery. This is another tumor. Let us see. You see, this is supracerebral. You can see the basilar artery, vertebral artery bifurcation through a supracerebellar route, and you can do a beautiful resection. And what is important in neurosurgery is, of course, the exposure is important. Of course, the dissection technique is important. Your experience in handling the tumor is very critical. The quality of the tumor itself is very critical. And of course, you have to do, and you have to go on doing and doing all your life these kind of tumors. Tuberculum meningioma is also, I described 70 cases in 2002. My experience is more than 300 cases, which is also largest in the world in tuberculum meningioma. This is my personal series of 129 cases of olfactory groove meningioma, which is also largest in the world. Anterior clinoid meningioma, I gave a classification in 2000, which is also a huge series of anterior clinoidal meningioma. I described for foramen magnum meningioma, we know about extreme lateral approach and all these kind of exposures. I described conventional posterior cranial fossa midline exposure for these kind of tumors. Now I have got a very huge series where I have done just this kind of exposure, little bit suboccipital craniectomy, C1 laminectomy, exposure of the vertebral artery early in the operation, and working within the nerves, break into the tumor, and you can do a beautiful resection. I even removed ossified foramen magnum meningiomas by, you see this tumor, it is completely bone, and it is encasing the vertebral artery. And this tumor was completely removed. I have a follow-up of more than 15 years on this particular patient. This is another tumor. You see, both vertebral arteries are encased and completely ossified tumor. Within the tumor is the vertebral artery, and this tumor was removed. And I have got very long follow-up of even this case. This is another tumor, foramen magnum. You see, completely ossified. You can imagine located anterior to the brainstem, having complete dark ossification, and this tumor within the cranial nerve, and this tumor has been removed completely and beautifully. What is important is learn the art of handling the tumor and breaking the tumor, and you can avoid very extensive exposure for such tumors which can be removed. So in meningiomas, curing is not, you don't have to remove the meningioma, you have to save the function of the, curing is you once a meningioma, always a meningioma. Recurrence of meningioma, you see this beautiful sentence, recurrence of meningioma is independent of the extent of tumor resection. It is not the treatment, but the cellular behavior that decides the clinical outcome. So thank you, my dear friends. I hope you have enjoyed my lecture. I hope I was able to give you some nice little small tricks. George, Byron, I hope you are happy with what I have talked about. Thank you very much. And it has been my pleasure to talk to you.
Thank you so much, Professor Atul. I mean, that's a masterclass lecture. We are proud to say that your experience has no equal. Your technique, your knowledge, all the knowledge about the dura, all the time that you have been working with these kind of patients, I guess they are pretty lucky that you could save their lives. And we are lucky because we are learning so much from you, from all your experience. And we really appreciate for all your experience in the field. I guess we can now start with some comments from the panelists. We have here Professor Loyo, Professor Kohn, Professor Amador, Professor Facchini. I don't know if any of you have any comments. Dr. Loyo, please go ahead.
No, you have to unmute.
Unmute, Dr. Loyo.
Dr.
Okay,
Loyo está...
Dr. Gold.
Yes.
Yes, I have the sound now.
Yes.
Dr. Gold, the two questions. You never use the combined supra and infracellular approach for the treatment of the large hypophyseal tumor. I published this approach many years ago. You never is in 1985. You never use this approach?
No, I have never actually.
One of the questions.
Yeah, I have never actually combined. I have never combined transcranial and transnasal route. I have never combined. Sometimes what happens is
I never come in the same time.
Never combined, because sometimes if I'm not able to remove from the nose, I may go transcranial at a later date, not at the same stage. So that is my strategy.
Okay, the another approach is the sublabial ampliate approach for the cavernous sinus for the skull base, because now you know the more of the people use the extra dural skull base in Cordman, in pituitary, and it's possible. I describe this approach in the book of the Vincon Dolan about the sublabial ampliate approach. You never see?
No, I do sublabial. I use like Jules Hardy's approach. I use. We also use endoscope for removal sometimes. But what
yes, the endoscope now is better.
Yeah. But what my presentation is basically talking about the philosophy, about the dural relationship, about when to go from the nose, when to go
and
from
what
the
is your experience? What do you say about this approach?
Of course, transnasal approach is very important for chordomas, very good approach for selected cases. But I have also to say that transcranial route is also very important for selected cases. And transnasal approach can be used for pituitary tumors, but never for cavernous hemangiomas, which I showed. If you use cavernous hemangioma transnasal approach, you can damage the person. I shared that nasopharyngeal angiofibromas, you use transnasal approach. I used to do transcranial route. I don't use transcranial route. So we have to learn, and we are, as you know, from our experience, we have to go on improving and learning and developing our own approaches.
You know this approach. You read the book of the Vincon Dolan about the skull-based surgery.
Yeah. Vincon Dolan is, of course, my personal friend, and a personal friend for a very long time. And we know about his work on cavernous sinus. And we have learned so much from Vincon Dolan. I know him very well personally. He's my very good friend. Yes,
he's a very good friend mine that he invited to me and he write this papers. Thank you very much. And do you think your opinion is good in any special case? What is the special case? What do you, in your opinion?
No, I
when did you use this approach?
For pituitary tumors, sublabial approach? Which approach?
Yes, in your opinion, what is the best use for this approach in this tumor, in Cordman, in pituitary tumors, with the coming to the skull base, and you need the open the cavernous sinus for the frontal approach. You look and you not touch the nervous, and you escalate the carotid artery in the base and in the intracranial, and it's very, very clear the situation of the tumor, and it's very easy to remove this tumor now with the endoscope. In the last time in 85, which is I described this approach is not endoscope. I use the microscope with the big window, and it's possible looking very clear all the structure of the skull base around the cavernous sinus.
Yes, of course. I agree with you completely. I completely agree with you. For pituitary tumors, for chordomas, endoscopic work and transnasal route is a very good operation. I agree with you. And for even when the tumor goes in the cavernous sinus, I like to do transnasal route, but if cavernous hemangioma, transcranial route, selected chordomas, transcranial route, trigeminal neurinoma, transcranial route.
Yes.
So for each tumor, different route. That is my strategy.
Yes, this route is the better because you remove the external wall of the maxillar sinus, and you had a big hole really, and looking very clear all the structure of the skull base. That is my idea when I describe this approach. And the last question is, I would like you to treat the remove in the big tumor or the pituitary tumors with in the same time use the remove the supracellular and the infracellular. You present the very nice drive in the, you put the woman with the same, with the one boy he's born.
Yeah.
It's the same because you push to the intracranial and you receive in the sphenoidal for the transnasal or sublabial approach all the tumor, and it's a big decompression, and it's very easy coming to the intracavernous sinus with you remove completely the tumors, and very easy really because you only push the tumor in the intracranial and receive in the transnasal cranial all the tumor. It's a very easy, and I present the second papers in archive of the world about what is the indication of this approach, the years and the condition of the patient and the Karnowski. I think so. I would like because you had a very good experience. You had a very numerous case. Is the same with the Mexico with you big tumor because the people coming late to the doctors. I would like you try it. I invite you try this approach.
Okay.
And thank you very much. It's a fantastic presentation. Congratulations, doctor. It's a pleasure listening to you.
Thank you so much. Thank you.
Thank you so much for your comments, Dr. Loyo. We have here Juan Luis Gomez Amador, experienced school-based surgeon. And regarding that, we are discussing the use of the endoscope. I would like to ask him, what are the advantages and limitations of endoscopy to the cavernous sinus?
Yes, thank you very much, Dr. Salazar. Definitively, it's not a surprise. We are all gladly impressed by this enlightening and comprehensive lecture, not just about the cavernous sinus, but the entire skull base. I like a lot the embryological anatomical concept of Professor Goel concerning how to deal with the tumors, preserving the different structures that cover the tumor. And he also showed us a very important thing, that is the concepts of Professor Yashargil, precise understanding of anatomy, a very acute tridimensional sense, but also he showed us the courage to perform the different surgical maneuvers with a common sense. So if the tumor is covered by the dura, don't touch the dura. So this is a very important matter concerning the treatment of these skull-based tumors. Now, I know Professor Atuguel knows the development of endoscopic endonasal surgery for skull-based lesions. And I know that there have been some abuse in the indications of endoscopic endonasal approaches, and he showed us different corridors in which we can go and treat lesions in the subarachnoid space or in the interdural approaches. And I think, as he mentioned before, endoscopic techniques are useful for the treatment of certain pathologies in the skull base. Concerning specifically what you asked about the pituitary tumors, I believe that the pituitary tumors, when you come by the nose, it's very easy in most of the cases to take out the tumor that is invading the cavernous sinus, because this is a very soft tumor. And as Professor Goel said, it takes 25 to 45 minutes to take out the tumor. If you are using more time, perhaps you are not doing a proper strategy to demolish the tumor. This is a very interesting concept, to learn how to demolish the tumor, to take out the tumor in a proper fashion, but using this common sense, right? So this is a very appreciable thing, Professor Goel. I think one of the most important things that you have shown us is that the pathology in your country is very similar, as Professor Loyo said before, in that we are looking in our country, and even in the whole Latin American area. So we need to take advantage of your expertise, and the most important concept is this embryological anatomical combination and the precise concept of to learn how to demolish the tumor. I appreciate that a lot. Thank you, Professor.
Thank you.
Thank you so much for your comments, Professor Amador.
I think we had a slowdown in Atul.
Yeah, I guess he's not.
He's like, just hang in there. He always comes out. It's siempre regresa. Go ahead, Atul.
Yeah. See are you able to hear?
Yes,
John?
yes, perfect.
Okay. So basically what I will like to do is, my next presentation, I will like to talk on craniovertebral junction and spine. And
Yeah,
I want
perfect.
to give you some concepts on craniovertebral junction and spine. And then, as I mentioned to you, I will like to talk on arteriovenous malformation. So let us organize this, Baron, and make it a beautiful series. And so next will be craniovertebral junction. And I want to introduce to the Latin America. I think Latin Americans are not very familiar with craniovertebral junction treatment. This is my impression. I am not sure. So I want to give you a very elaborate discussion on the craniovertebral junction problems and treatment. And then I will,
sure, Professor.
And then I will introduce you to some additional facets about instability of craniovertebral junction and spinal instability. So I hope I can give you some new information in my subsequent lectures. Okay, Byron?
Yes, for sure, Professor. We will be delighted to organize your seminars, and we will be sending you the specifics, the date and time. But I guess it's a nice way to learn from you.
Thank you very much. Thank you. So, John?
Byron?
John, I guess my dad's speaking, but I think he's muted somehow, that it's not reproducing its sounds.
Can I have some comments from George?
Go ahead.
Yeah, he was speaking, but I guess there is something wrong with the Zoom, that his voice doesn't sound.
Yeah.
Meanwhile, Professor Atul, I have lots of questions here that are regarding the demolishing of the tumor. You have spoken a lot of how to learn to demolish, and one of the most questions that many of the residents specifically have is, what instruments do you use? What are your settings? And what is your way, actually, the technical issue to learn to demolish those tumors?
See, demolition can be learned only by, more the experience you get, more and more tumors you get, more and more you love your subject, more and more you are in the operation theater, more tumors. You can hear, Byron, you're hearing?
Yes, Professor, yes.
So more you operate, more you do, more you are in the, you should love to operate. You should love the smell of the operation theater. You should be always in the operation theater. If you do that, your technique will improve. Your quality will improve. You have to, you see, what you have to do is debulk the tumor, break the tumor, respect the membranes, respect the blood vessels, respect the perforators, respect the cranial nerves, tease the tumor of these tissues. You see, nobody can, you have to just do it. And you have to have that will, and you have to have that confidence. You see, many of my tumors are very vascular tumors. I will show you one, I will give you one presentation of AVMs, arteriovenous malformation surgery. You can imagine arteriovenous malformation means bleeding, bleeding, bleeding. You have to know how to operate in bleeding situation. And if there is bleeding, you don't have to keep on burning, coagulating, coagulating, coagulating. If you go on coagulating, you will never finish the operation. So that is very important, like in acoustic tumor. In acoustic tumor, you need to coagulate very little. If you go on coagulating on, if you go on coagulating, you will never be able to finish acoustic tumor surgery. So it is very important to understand that you have to learn to operate in a bleeding territory, and you have to know which vessel has to be coagulated, which vessel has to be avoided. So these things have to be learned. George.
Do you maybe use the CUSA for your surgeries?
CUSA, of course, it can be used, but unfortunately, I don't like that CUSA instrument. I use my suction, and I have a controlled suction where I can move the thumb and break the tumor. And very rarely I use CUSA. CUSA is a good tool, and I don't discourage people using CUSA. But if you ask me personally, I don't like CUSA very much. Sometimes, rarely I use it.
Thank you, sir.
George?
Professor Atul, your experience is so great, and many neurosurgeons from all over the world cannot do the things that you do. So there is a learning curve that has to be learned step by step. Perhaps you can summarize some of the first steps beyond learning the anatomy, doing a right diagnosis before a surgery, and also dissection techniques to avoid the injury to the nerves and the arteries.
I will invite you all to visit me in India, and it will be my pleasure to host you. I conduct very often workshops. In my department, we conduct at least 3 or 4 workshops every year, and those are very heavily attended workshops. And I wish that people from Latin America can come and spend some time with me, and it will be my pleasure to host you and your younger colleagues. As regards the technique, you see, technique is every surgeon has its own technique. Most important thing is we have to learn the art of controlling bleeding. We have to learn the art of respecting bleeding. We have to handle blood loss throughout our life. We have to learn how to handle the anatomy, respect the membranes, respect the dura, respect the arachnoid matter, respect the perforators, respect the, so many things, George. As you know, neurosurgery is a huge subject. We have to enjoy it. Basically, we have to just live neurosurgery. And if we live and learn, love to live neurosurgery, we can do whatever we want. And that is what I have done in my life.
Juan Lewis, did you have a
Thank you,
question?
Professor.
Did you have a question, Juan Lewis, or comment?
Yes, sir. Professor Goel, when we are teaching the residents in the OR, what do you think is the role of use the Doppler, navigation, and all these tools to increase the safety of the surgical procedure, and also to get familiar the resident with the anatomy that we are facing in the patient? And a second question, what do you think about the use of multi-layer reconstruction techniques for those big spaces that we are living after taking out a huge tumor?
Okay, so, I will answer the second question about multi-layer reconstruction and vascularized pedicle reconstruction. One is reconstruction using free flaps, free grafts like fat and muscle and all. Second thing is vascularized pedicle reconstruction using of pericranial layer, temporalis muscle, and facial layers. So you must read several articles of mine on reconstruction. I am sure you must have read my vascularized bone flap reconstruction, osteomyoplastic flap, subgaleal fascia flap reconstruction. I have described at least 20 flaps for reconstruction, including multi-layer transcranial reconstruction, multi-layer middle fossa reconstruction. So these are very important. As you know, reconstruction is the most important thing. You do a good operation. If you don't do reconstruction, you will have a failure. As regards the use of technology, you see, technology is very important. Technology, but philosophy is the most important. You have to know the art of the subject. Technology will help, but philosophy will take you to the point. You need navigation. Of course, you need navigation, but you cannot be dependent on navigation. You have to be dependent on your vision. You have to dependent on your anatomy. You have to dependent on your experience, and you have to dependent on how you. If you go on using, you see, I have seen people doing glioma surgery, continuous. You see the intraoperative MRI, this, that. The operation will go on for 20 hours. You see, if you go on doing like that, you should take the help of technology, but you cannot be a prisoner of technology. You understand what I'm saying? I'm not saying don't use technology, but if you cannot do the operation without the technology, then it is not correct. You should be able to do the operation even if there is no technology. Technology can help you, but technology cannot victimize you. I think navigation, ultrasound should be used, but they should not be. You should not spend hours and hours on using this kind of things. We use technology, we use navigation, but I will also tell you, during my experience of so many years in skull-based surgery, my exposures have become less and less and less, as I mentioned. I used to do extensive petrosectomy. I used to mobilize the facial nerve, carotid artery all the time. But over the period, my exposure has reduced. Similarly, my dependence on technology has remarkably reduced. Like navigation, I use it is always in my theater, but I use it very rarely because I don't think it is absolute indicator of using technology all the time. So I think it is good tool for teaching residents and teaching young students, but they have to be taught very important lessons in anatomy. And when you open the brain, you have to teach them that where exactly is the motor strip, where exactly is this sulcus, where exactly is this sulcus, where are the white fibers, where is the IFA, where is the uncinate fibers, where are the arcuate fibers, rather than having dependence on, of course, glioma surgery. I will give a lecture if Byron asks me on glioma. I want to give a lecture on my strategy of glioma also. I will give. I hope in a subsequent. So I will have a series with you with multiple lectures, and over the series I will give you my surgical strategy on various subjects. So Byron, so be prepared for a long series and a long winter with you. Okay?
Perfect, sir. We will be waiting for you. One question that is a complement from Dr. Amador's questions. about the monitoring of intracranial nerves during surgery. You think you said that you use or you don't like to use a lot of technology. So what would be the key points to find the nerves in the cavernous sinus? Because we all know that they're going to be displaced and some of them will be covered. So what's your strategy to find them?
See, it is very important question. For those who are doing cavernous sinus surgery, this is a very critical question. And you have to know that the nerves enter and nerve exit. These points remain stable. Like sixth nerve enters in the dura. That point remains constant. You see, so if you have to identify the nerve, you have to identify the entry point from where it is entering into the cavernous sinus. So if you have to identify the third nerve, you have to identify from its entry point. So this is a very important question. Basically, these things are very, when you are doing intracavernous sinus surgery, like cavernous hemangioma, that time you don't need to identify third nerve, fourth nerve, fifth nerve, because they are outside in the dura. So it is very important to know what tumor you are operating. And in that situation, you have to identify the sixth nerve, and you have to identify how the sixth nerve is displaced by the tumor on the lower aspect, on the inferior aspect, along the floor of the cavernous sinus. So that is important to know where the nerve will be displaced. Like chordomas, can you answer this question? Where is the sixth nerve displaced in chordomas, Byron? Can you tell me where the sixth nerve is displaced in chordomas? It is a difficult question. Nobody can answer this question. Nobody has ever written on this. So if you read my paper on supracerebellar approach to clavicle chordomas, I have mentioned that the sixth nerve is carotid artery is displaced anteriorly and the sixth nerve is displaced superiorly. So the distance between carotid artery and the sixth nerve becomes increased in a clavicle chordoma. So this relationship is so important. Basically, every tumor you have to do in a different manner. Meningiomas are one issue where you have to identify the nerve in the tumor, and that it can be a little bit dangerous and difficult.
Thank you so much, sir, for your answer.
We have a question from Dr. Luis Sulca. Dr. Sulca, go ahead. Do you have a question?
Go ahead, Dr. Solka.
I guess not. I would like to make a question to Dr. Aldi Shah, since she is a master in anatomy. So this is a basic tool that every neurosurgeon should dominate. So I would like her, she can give us some pointers on in relation to the structure of anatomical structure of the cavernous sinus. Please, Dr. Abdiya Shah. Can you unmute yourself? Thank you.
Yes, Professor George. I didn't hear part of your question. What did you say?
Anatomy of cavernous,
anatomy of the cavernous
anatomy
sinus.
of cavernous sinus.
What is the protocol to learn? How do you train the main pointers about the anatomy?
So anatomy of the cavernous sinus, you have to understand how the nerves are displaced and how they run in the dura. Basically, you start with learning of the dura with the extradural approach as Professor Goel has described. And once you start, when you go on your cadaveric dissection and you start peeling off the dura, then you start identifying the nerves on the floor of the middle fossa one by one, and you see their relation with each other and the triangles that they make. And then once you identify the lateral wall of the cavernous sinus, then you go on the roof of the cavernous sinus to identify which nerves are present on the roof, then which nerves are present on the posterior wall of the cavernous sinus. This is one aspect of the cavernous sinus. And the other one is the carotid artery. Basically, how the nerves are in relation to the carotid artery is another important point that you have to understand when you're doing the dissection. And you will get this three-dimensional perspective only once you do the dissection yourself. By just seeing on the photographs or something, you will not get that appreciation. So it is always better to do a cadaveric dissection and then of course see many operative videos to get that understanding.
Thank you, Professor Abisha. I would like to ask Professor Kugoel, you have said that you have revolutionized the study of cavernous sinus surgery based on the anatomy of the dura mater. This is a very interesting point. When you see a tumor, you can say if it goes beyond the dura mater or not. So how can you differentiate on magnetic resonance image? When do you have to perform a surgical approach from a tumor? Should be intradural, extradural? What is the importance when the tumor displaces or encases the internal carotid artery?
See, basically, every tumor has a discrete relationship with the dura. Every tumor will have a very special relationship with the cranial nerves. Every tumor will have a very special relationship with the carotid artery. So that we have to know which is what tumor. Like, for instance, chordoma has a different relationship with carotid artery. Pituitary tumor has a different relationship with carotid artery. Trigeminal neurinomas have a different relationship with carotid artery. So every tumor has a very special relationship with carotid artery and with the cranial nerves. And we have to visualize the tumor on the basis of what tumor we are going to operate. We have to understand what is the tumor on the basis of clinical findings, on the basis of radiological findings, on the basis of MRI findings, and various, and your own personal experience. So, George, these are matter of individual tumors that we have to understand. When the tumor is encasing the carotid artery, that is a different tumor. Like if it is a meningioma, you have to organize that tumor surgery in a different fashion. Pituitary tumor, carotid artery encasement is a very common phenomenon, but the tumors are very soft. Pituitary tumors, meningiomas are firm tumors where the dissection can become difficult. So it will depend on the vascularity of the tumor, consistency of the tumor, nature of the tumor, and on various other factors as to how you dissect in each individual situation. As far as the dural relationship of the pituitary tumor is concerned, I'm sure you must have enjoyed this discussion which I made, but this was not there, this information was not there 20, 25 years ago. Even the trigeminal neurinoma, which I showed the interdural relationship, this nobody knew 25 years ago, nobody knew how to operate trigeminal neurinoma during those times. And as I mentioned, everybody used to operate in 2 stages. And preserving of the trigeminal function, nobody was talking about trigeminal function preservation in trigeminal neurinomas. So these are very important issues. And transcranial surgery was so common for pituitary tumor. Like everybody used to do transcranial surgery for pituitary tumor 30 years ago. So what we have done is, I have no doubt about it, that these kind of understanding about dura and all those things have helped completely understand these problems, and the surgery has become much simpler, particularly in my own experience.
Thank you, sir, for your comments. I would finally like to comment something and, get the thoughts of the more experienced ones about cavernous sinus meningiomas. It's a controversy theme. We have a lot of management options. We can observe it. We can do some microsurgery. Or sometimes they can have a radiation treatment, or in some places like in Europe, even an immunotherapy like checkpoint inhibitors. And we know that observation for those tumors basically are because are benign lesions. They show slow growth rates. Usually they are small, they are not life-threatening. So maybe, as one said, we all do not have your skills, and maybe a surgery involving that area would end in unfavorable results following surgery. And we have to know, of course, the natural history of cavernous sinus meningiomas. And some papers in literature say that they might not even change in 75% of cases, or their growth will be so slow. So the goals of microsurgery would eventually be the cure of the disease, and that's one point of discussion, the relief of symptoms, and of course the histopathological analysis. And we know that the degree of resection of meningiomas will depend on the degree of internal carotid involvement, and maybe subtotal resection would be, in some cases, an effective strategy. And regarding that, radiosurgery treatment should be reserved maybe for some remnants with secondary growth and some clinical manifestations. And that being said, and my question for you, Professor Goel, and all the panelists, what will be your philosophy of treatment for these meningiomas in the cavernous sinus?
Okay, Byron. So this is a very interesting question. So what I will like to do is, I will like to share my screen, okay? Just a minute. And you see the screen.
Sure. Not yet.
Now you can see the screen?
Yes.
Yeah.
So you read this beautiful line. You see, I mentioned, I showed in my presentation that cavernous sinus meningiomas which enter into cavernous sinus are inherently more aggressive. I mentioned this. And cavernous meningiomas which go into the sinuses are more aggressive. They are like malignancies. So we should never, you see, curing, we should never operate. We should see to it that we preserve the function. Like if the third nerve is going to be damaged by your dissection, don't do that dissection. If you are going to damage a perforator, you have to leave that perforator. So don't go for a cure. You have to have a symptomatic. The patient should recover. If you have to leave some tumor behind, you leave it. But you don't try to be curing the person. Another beautiful sentence I am giving you, and this is particularly true for cavernous sinus meningioma. You know, we talk about Simpson grading, we talk of removal of the dura, we talk of removal of the bone, and we talk of this and that. But in general, my philosophy is this. My philosophy is that recurrence of a meningioma is independent of the extent of tumor resection. So this is a very controversial statement which I had made, but this is a very important statement that you do the surgery within the safety limits as much as you can. You cannot don't overdo it. So in cavernous sinus particularly, this is very important. You do radical resection. You do very radical resection, but don't try to, don't try to cure the person, because recurrence is not in your hand. That is the second thing. You see, this is the beautiful statement that I am keeping for you. It's not the treatment, it is not the extent of resection, but the cellular behavior of the tumor that will decide the recurrence. So these are some statements regarding meningiomas. Other thing is the need for radiation treatment. You see, if you leave some tumor behind, you give radiation. I don't like that kind of philosophy. I don't like, I don't do, I don't give. Unless if the tumor recurs, I like to reoperate. I will give radiation only when I think that I cannot reoperate. I am not able to operate. So when my knife is not able to handle, then I use gamma knife. Surgical knife first, gamma knife last. That is my philosophy. Byron.
Thank you, Professor. We have a question from Omar Hamoud. Please, Omar,
Okay,
ask your question.
thank you, Dr. George. Thank you, Dr. John, Dr. Adol, Professor. Thank you, good presentation. I asked Dr. Professor Adol from the past 30 years ago for you. The first idea of first time you noticed that about to preservation the neuronoma for trigeminal nerve. What's your idea at that time? You find what you noticed that time when to think to trigeminal nerve in cadaver or anatomy or what you see.
Basically, you know what? My advantage was that I work in a factory. You see, in a factory of patients. You see, we are operating so much, and that is my advantage. I have got several disadvantages in my country. India is not a rich country, or it is not America, it is a poor country. But we have advantages like number of people, number of patients. We operate free of cost. There is no money charged when I operate on my patients here. So because there is no money, there are so many people, we are operating 17 cases, 15 cases. You see, like that on a regular basis. 10 cases on a routine, we do 10 neurosurgical major cases in a day. So that is the advantage that we are having. Sometimes I personally operate 10 cases. Sometimes I have operated 13 cases in one day personally. So that advantage, I use that advantage. I have used that advantage over several years. And that has given me a solid, you see, nobody can argue with me because of my power of my patients. But if you ask me, how much money I have made, I'm not a rich man. You see, because I don't get so much paid. I am working as a full professor. So that is the disadvantage. But I use my advantage. Neurosurgery volume is my advantage. The number of people that I operate is my advantage. And the quality of my residents and quality of my associates is my advantage. I've got top level people working with me. So that is my advantage. So I use my advantage. And that is what I have done in my life of neurosurgery.
Thank you, Professor. And I guess that's one of those things that actually, for example, Ecuador doesn't have. We all have like 30 million people total in the whole country. And of course, we can't have the numbers that you have. And that is why like some other countries from South America, or maybe in a small place in Europe, have used, for example, that radiosurgery for meningiomas in the cavernous sinus because of their effective controlling the disease, 95% over 5 years, maybe 90% over 10 years, compared with surgery alone. So what we are seeing in some cases is that, they make a surgery, of course, not your kind of surgery, but the remains are actually still big. And of course, they send it to radiosurgery and hope to keep the disease controlled. Or in some cases, well, when they are small, they tend to irradiate first. And the question will be, we know that their growth will be slow. So how can you tell that actually the tumor is growing? Because we know that when some center makes the MRI, they can have some different operator do the size of the tumor, and it will give 1, maybe 2 millimeters in difference, and maybe that's not even true growth. So what will be your experience to tell us to know to be sure that these tumors are growing in time?
The best thing is don't give radiation to benign tumors. You give them, you operate and remove them. And when you do a safe operation, you do a if necessary, do a conservative operation, like for acoustic tumor. Like for acoustic tumors is a beautiful neurosurgical material. My feeling is that all our young people should learn how to operate on acoustic tumor. But if you give facial nerve palsy in 100% of patients, then the patient should go for gamma knife. If you are giving him palsy of the facial nerve all the time you operate and there is a full palsy, then the patients will be happier with gamma knife, because at least there will be no palsy. So you have to learn how to operate, and you have to teach young people how to operate, and you have to teach how to save the facial nerve, and you have to teach how in large tumors how to stop, when not to dissect, when not to tease the facial nerve, where not to touch the facial nerve. I will give you my philosophy of facial nerve large tumors. My philosophy of large facial nerve tumor is very clear, that in large facial nerve tumors, which are more than 4 centimeters inside, you have to always leave a shell of tumor on the facial nerve. If you say I can remove the whole tumor without leaving a shell of tumor, I don't believe you. I've got so much experience in acoustic tumor surgery that if you try to tease the facial nerve from the capsule, you will certainly damage it. So you leave a small shell of the tumor. That is my philosophy. Even in large acoustic tumors, you can do a beautiful operation. The problem comes in very small tumors, very 1 centimeter or 1.5 centimeter. In that, the problem comes whether you want to operate or whether you want to give gamma knife. So those tumors are a little bit controversial. In my hospital, in some cases, we do give radiation, but in general, if it is a situation 1 centimeter, maybe I just observe him for several months, several years, and if it grows, then we operate. Basically, to gamma knife and radiation should not, I don't personally like it. I don't personally give it. I don't want to recommend it. I want young and senior neurosurgeons to operate beautifully. I want them to learn to save the nerves. I don't want them to give, radiate, and finish. Then where will be our neurosurgeons become neurosurgeons? When they will become technically profound. But also we must remember, we cannot learn by doing wrong things on the patient. We cannot make 10 facial palsy and then say, okay, I have learned on 10 patients. You cannot do like that. Every individually, every human is important. We have to be masters on the first case. We cannot say, okay, young fellow, you operate, you don't worry about the facial nerve, everybody facial nerve, but you think about the patient. You know, even in my hospital, I was saying my patients are poor, but poor does not mean that they don't like their face. You understand? Some people told me that, oh, your patients are poor, they don't bother about their face. Completely nonsense. Even the poor person likes his face. Even young people like their face. Old people like their face. Girls like their face. Boys like their face. Face is your identity. You cannot say, okay, operate and facial nerve palsy. I am not saying that I don't give facial nerve palsy. Don't misunderstand me. There are several acoustics where I get facial nerve palsy. But if you give facial nerve palsy to 100% of patients, then you should not be operating acoustic tumors.
Thank you, Professor.
Thank
We
you,
have
Byron.
seen
Thank you.
a very experienced neurosurgeon telling us how to do very complicated surgeries, but we have many young neurosurgeons, we have residents, they are wondering how's the natural step by step, how to learn these techniques. So there are certain levels in the learning curve that every resident or neurosurgeon should achieve. For example, on the first level, perhaps you're going to operate a tuberculum cell meningioma or sphenoid breach meningioma, but you have to do certain specific tasks. For example, how to do the peeling, how to do the anterior clidenectomy. Second, if you have another second level, more complicated, like a lateral paraclinoid aneurysm, you have to take out the outer rings or the inner rings so you can approach the arteries. So I would like to ask some of the professors here in the chat, they have a lot of programs in their postgraduate students. Do they teach that in a very specific manner? For example, I would like to ask Professor Juan Luis Gomez Amador and the other assistants, did they teach this in a specific manner?
Excuse me, sir, I didn't hear properly the question.
Yeah, in your postgraduate program, do you have this step-by-step learning curve so you can do this specific tasks to approach the cavernous sinus?
Yes, sir. We have a laboratory in the microsurgical department, and we try to teach the residents step by step the different parts of the surgical procedure. But as Professor well said, it is very important to teach them in the operating room. So they need to learn how to deal with these precise dissections in order to preserve the nerves, the arteries, the veins, and also the brain parenchyma. I think there should be a combination of both the cadaveric prosection and the specific models, and also the teaching in the OR.
Thank you very much.
Thank you
very much.
Thank you so much. I guess we don't have any.
Any more questions? I would like to thank a lot Professor Goel for teaching us every time he gives his lecture. We all learn a lot, and I would like to thank Professor Juan Luis Gomez Amador, Professor Loyo, Professor Facchini, every one of the participants today for being with us on a Saturday. We really appreciate, and we will be seeing you in 2 weeks. I like to thank, of course, Neurosurgical TV and John Bennett for this opportunity. And I guess, and I give you all of you a good day and have a nice weekend.
Thank
I
you.
will like to talk next time on craniovertebral junction. And I will like to show my philosophy on Chiari malformation, syringomyelia, and things like this. Okay?
Yeah.
Of course,
Thank you.
Professor. We will
Thank
set that up.
you. Thank you.
Thank you very much.
That's why they call him he's the king of Zoom in neurosurgery. That's why they call him that.
Thank you,
Thank
John.
you.
Yeah.
Thank you, everybody.
Thank
Thank
so
you,
much.
Professor.
Bye-bye. 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 Bye-bye.